Welcome to today's office hours on irritable bowel syndrome. And before we get started, let me just clear up a little nomenclature. Irritable bowel syndrome is abbreviated IBS. Inflammatory bowel disease is abbreviated IBD. And I see such a gamush of these two terms. I see it described as irritable bowel disease, no such thing. Inflammatory bowel syndrome, no such thing. So IBS, irritable bowel syndrome, completely distinct set of problems from inflammatory bowel disease, IBD. When we talk about IBD, we're talking about two diseases, Crohn's disease and ulcerative colitis. And these are both autoimmune conditions that affect the GI tract. Separate, nothing to do with irritable bowel syndrome, except to further confuse things, some people with inflammatory bowel disease, Crohn's disease, or ulcerative colitis also have irritable bowel syndrome, and they can have symptoms, although often it's their IBD causing the symptoms, but there are circumstances where they can have IBS on top of IBD. So today we're talking about IBS, irritable bowel syndrome. This is one of, if not the most common conditions in the US and affects a lot of people globally. The incidence of this disease, or rather the prevalence, ranges from 15% to 25%, depending on what studies you read. And some people have even postulated maybe as high as 30% of the population. Now, here is the main problem with IBS, because this is one of the commonest things you'll see as a gastroenterologist. So even though in my practice, I do a lot of work with IBD and people with complex autoimmune problems, I also see a ton of bread and butter IBS. And one of the biggest problems we have in the gastroenterology community is that we are lumping instead of splitting. So we are taking everybody with a wide range of symptoms and putting them together under this banner of functional gastrointestinal disorders, FGID, okay? Functional GI disorders, or functional gastrointestinal disorders, which includes things like functional dyspepsia, irritable bowel syndrome, some motility problems. But we are not doing a good job of figuring out specifically why our patients have these symptoms. So we're lumping things together, and we're lumping categories of things together that really don't belong. So let me explain a little bit more what I'm talking about. By definition, when we say irritable bowel syndrome, it means that we have excluded other conditions that are not functional. So when we say functional, we're really meaning there is not a clear anatomic correlate. So colon cancer is not a functional bowel disorder. There is a lesion, a cancer that's causing symptoms. Diverticulosis, not a functional disorder. There are potholes in the colon. Hopefully you join me for that one. That's one of my favorites. If not, go back and check the archives and check it out. So diverticulosis are these potholes in the colon that develop primarily in the lower part of the colon that can cause a lot of symptoms that mimic IBS. Diverticulosis can cause bloating, motility disturbances, gas, change in bowel habits, all kinds of issues, constipation. But by definition, if you have IBS and you also have diverticulosis and you have those symptoms, your IBS diagnosis is in question because all of those symptoms can be attributable to your diverticulosis. So what I find, and without throwing too much shade on my GI colleagues, I would call it lazy doc syndrome. Your gastroenterologist, your primary care doc, whoever's treating you, needs to literally roll up their sleeves and figure out what the specific cause of your symptoms is. It's not good enough to just say you have IBS. What does that really tell you? Do you have a motility disorder, either too fast or too slow? And if you have a motility disorder and things are moving too fast, is it because you have diabetes that's affecting the nerves to the enteric nervous system and speeding things up, can also slow things down? Is it because you have dysbiosis or SIBO, small intestinal bacterial overgrowth, and that's causing a motility disturbance? Is it because you're taking a medication, like a laxative, that's speeding things up? Or a vitamin with iron in it that's slowing things down, or a narcotic for pain? So medicine cabinet is another huge category. I cannot tell you the amount of people I see with GI complaints who tell me they've been diagnosed as IBS, and I have them bring the entire content of their medicine cabinet, prescription, over-the-counter supplement, and right there in the bag of all these pills they're taking is explanation. Maybe they're taking magnesium at night to calm themselves down, but it's also giving them diarrhea. Maybe they are taking something with senna in it for constipation, and it's giving them loose stool and gas and bloating. Maybe they're taking something with an artificial sweetener in it. We'll come back to all of those. So the medicine cabinet is another big one. The microbiome is another big one. We see people who have imbalance in the microbiome, what we like to call dysbiosis, a damaged microbiome, either as a result of diet, as a result of overuse of antibiotics, acid blockers, a whole range of things that can cause that, previous infection. And they have classic dysbiosis, which can, again, present with a motility disorder, too fast, too slow, bloating, gas, change in bowel habits, all of these things. But they're just being given this label, irritable bowel syndrome. So there's mechanical issues. You could have fibroids and a fibroid uterus that's pressing on your colon, causing symptoms. You could have, again, things like diverticulosis. You could have celiac disease or gluten intolerance. You could be lactose intolerant. So these are all distinct pieces of the IBS pie. And really, if you, ideally in conjunction with your healthcare provider, don't really sort of do some medical detective work, you're just going to end up with this generic label, IBS-C for constipation predominant, or IBS-D for diarrhea predominant, or IBS mixed type. You're having a little bit of both. And they're going to recommend a drug. So not to say that there's anything wrong with recommending a drug. Again, medications play a huge role in a lot of the problems we have generally, as well as in our digestive tract. And I am always saying I'm thrilled that we have these medications, but I want more judicious use. So for example, if you have been diagnosed with IBS-D, with diarrhea predominant irritable bowel syndrome, but it turns out it's because you're on a medication that's causing diarrhea, I don't want somebody to add another medication. So now all of a sudden you're on Lamotil, because then we're really just using a drug to treat the side effects of another drug. And then you start getting into this polypharmacy, and then you get side effects of that drug. And now and so 4 medications later, nobody has uncovered the root cause of your symptoms. So one of the first things I do when somebody comes in and says to me, I have a diagnosis of IBS, is I slice up that pie and I want to know, again, is this a mechanical problem? Is it a motility problem? Is it a microbiome problem? Is it a food intolerance problem? Is there an issue with inflammation? Do they have undiagnosed Crohn's or ulcerative colitis? Is this a food-related problem? Maybe autoimmune like celiac disease, maybe lactose intolerant, maybe they have too much fructose in their diet. And so I really want to pinpoint it because, again, if, for example, you have a form of fructose malabsorption, and remember, our bodies can naturally absorb, or small intestine, around 15 to 50 grams of fructose. So that's a pretty significant amount. But if you're getting a lot of extra fructose, either it's being added to foods or you're, eating tons of fruit and getting a lot that way, or a combination, the excess is going to be, it's not really malabsorption in the sense that your body can't absorb the fructose. It's an excess of fructose. That fructose is not going to all be able to be absorbed in the small intestine. It's going to flow down to the colon, where it's going to get fermented by gut bacteria, and it's going to produce gas. And so all of a sudden now you're going to have gas and bloating, not because there is an inherent error in your body's ability to absorb fructose, but because you've been eating too much fructose. So, again, we really want to drill down. And I like to use the analogy of chronic fatigue syndrome. Chronic fatigue syndrome is a real disorder, and it's turning out it's probably an infectious disorder and related to the microbiome, that there's often an infectious antecedent event, whether that's something like Epstein-Barr virus causing mono, or there are different types of herpes virus that can cause it, or SARS-CoV-2. Chronic fatigue syndrome, there's a lot of overlap with long COVID. But it would not be helpful for somebody who presented with symptoms of severe fatigue to just say, oh, you have chronic fatigue syndrome, I don't know, hair is like an amphetamine. We want to know why. Is this post-viral? Is this a post-viral syndrome? Is this related to undiagnosed hypothyroidism? Do you have an underactive thyroid and actually you need some thyroid hormone supplementation? Is this a side effect of a medication you're taking for something else? Maybe you're taking something for migraines or hypertension or something unrelated, and a side effect is fatigue. So again, you're not going to get to the right solution for you, or for anybody for that matter, if we don't know what the root cause is. So that's why I'm on such a, always on such a mantra about we must slice up that IBS pie and figure out what is the cause of your symptoms. The other thing I want to say is that for a significant percentage of the patients I see with IBS-C, constipation predominant IBS, or a mixed pattern, alternators, those who go from constipation to diarrhea, from feast to famine, a significant percentage of those people are simply constipated. That's the problem. They're constipated. Now, when you are plugged, remember, you've got this, 30-foot digestive superhighway, but things have to come out through the bottom. There's only one entrance and there's only one exit, unless you have a stoma, an ileostomy or colostomy bag, in which case you may have a second exit. But for the vast majority of people, there's one way for stuff to come out, and that's out through the rectum and anus. So what happens when that is blocked? It's plugged. It's plugged with a big stool, not coming out, and you're continuing to eat. Your digestive tract is continuing to break down those products of digestion. And your digestive tract is also continuing to secrete large amounts of digestive enzymes, hydrochloric acid, et cetera, all these different things. So there's liquid, there's solid, there's gas as a result of the digestion and fermentation, but it's all going nowhere. It's all sitting right there in your colon and causing a lot of bloating and discomfort. Simply unplugging you, figuring out an effective way, whether that's a combination of some psyllium husk or acacia fiber in the morning, a little magnesium or something at night, maybe even some Miralax, whatever that ideal combination is to unplug you, to make sure you're having good, efficient, and complete bowel movements, can in many cases completely take away all those symptoms of gas, bloating, abdominal distension, pain, cramping, and one of the hallmarks for irritable bowel syndrome in the diagnostic criteria is that the symptoms are typically relieved with a bowel movement, with defecation. Well, that is absolutely true of people who just have plain old, garden variety constipation. Their symptoms will be relieved with a bowel movement. So when I see somebody who has IBS-C, one of the first things I do is I really work hard to make sure I am unplugging them. And once they're, well-oiled pooping machine and they're having like a nice big stool the size of my head every day, I then re-examine and find out and reevaluate, okay, what's going on now with your abdominal pain, with your gas, with your bloating? Is it better? And if it's better, guess what? There's no IBS. You simply had constipation and symptoms of constipation, okay? So there are times when we are able to downgrade IBS from you actually don't have this condition. You just have some mechanical issues where you're plugged. Similarly, I see a lot of overlap with the dysbiosis and IBS. And dysbiosis falls onto the category of functional GI disorders because we can't really see it the same way we can see a colon cancer or diverticulosis. But it's distinct in a lot of ways, because with these functional bowel disorders, there is an assumption, spoken and written sometimes and sometimes not, that this is a gut-brain problem. And with dysbiosis, it's a gut microbe problem. And of course, the microbiome does communicate with the brain, right? But the main problem is that the gut flora are messed up. And that's what's causing the immune dysregulation, the motility problems, et cetera. So, the Rome criteria, for example, and we've been trying to categorize irritable bowel syndrome from the 1960s. We had the Manning criteria before we had the Rome criteria, named Rome criteria because it came about from a meeting in Rome. And so these things are 30, 40 years old, okay, in terms of how we look at this stuff. And we really need fresh eyes, because if you think about the last decade, what we've learned about immune dysregulation and, the microbiome and food sensitivities and mast cell activation, et cetera. I mean, it is a steep curve for what we know. And we still have a lot of people stumbling around in the dark, really not understanding what's at the heart of their symptoms, and just having been given this, quite frankly, fairly unhelpful label of IBS that really doesn't get them closer to the root cause of their symptoms. And while I'm all for Googling and cracking a book, hopefully one of mine, there's really no substitute for also having a relationship with a practitioner, be that practitioner, a nurse practitioner, a family practice doc, an internal medicine doc, a gastroenterologist, a subspecialized gastroenterologist, but somebody who really has some experience with this condition and can really guide you, right? Because it is still very much a diagnosis of exclusion. Like, I have people sometimes coming in with severe constipation saying, well, I think I have a parasite. And I'm like, well, what kind of parasite do you think you have? And they'll say, well, I think I have Giardia. And I have to explain to them that even though they may have read on a site somewhere that Giardia can cause gas and bloating, which it can, Giardia also causes diarrhea in the overwhelming majority of cases. And it's unlikely that they are the one case of Giardia where there's no diarrhea, or they have nausea alone. So, I'm a huge advocate for the citizen scientist and self-exploration and discovery and learning. But you really need to make that diagnosis and narrow it down in the context of experience. So somebody who has seen thousands of people with irritable bowel syndrome hopefully is paying a little bit of a different attention, right? And can understand the symptoms and put them in context for you. So by all means, come up with a differential, write notes, do all of that. But the actual diagnosis is, often takes a little more than just WebMD, because you can have symptoms of irritable bowel syndrome and go online and you might fit all the criteria for pancreatic cancer. Like, I've had this, I've had this, I've had that. You don't have pancreatic cancer, but, just lists of symptoms and sort of matching things up in a Venn diagram and seeing what overlaps really isn't sufficient. You really need that expertise with that clinical experience for, these are some of the symptoms, but what are the important presenting symptoms? How does this syndrome actually manifest in the real world? Okay, so we already have some questions. I'm take a quick break, and then I want to talk about FODMAPs diet. You can't have a discussion about irritable bowel syndrome without talking about the low FODMAPs diet. Lots of murkiness there too. So let me take these two questions, and then we'll talk about FODMAPs. Okay. I have had annual episodes of diverticulitis for about 10 years. My doctors put me on a course of Cipro and Flagyl for each episode to clear it up. After each course of antibiotics, I've been experiencing ever worsening IBS symptoms like food sensitivities, frequent bowel movements per day. Okay, so Andrew, thank you so much for sharing this. I do want you to go back and look at my potholes in the colon diverticulosis office hours if you haven't. It's archived, gutlist.com. Go to office hours, to the landing page. You can see all the archive ones, because this cycle of frequent antibiotics over and over and over, terrible for your gut and terrible for your diverticulitis. As you have experienced, it's not making you better. But even more importantly, Andrew, and thank you for bringing this up, when you have symptoms after those antibiotics, like food sensitivities and frequent bowel movements, that's not IBS. That's antibiotic associated problems in the gut. That's classic dysbiosis. So here's an example where they're lumping. They're treating you for a condition that you have, diverticulitis, with antibiotics. And as a result of the antibiotics, and you all who join me here frequently know the grim statistic that 5 days of a broad spectrum antibiotic, like you would use to treat this, that Cipro-Flagyl combination is potent, will remove a significant percentage of your gut bacteria, and some studies up to a third of your gut bacteria. So Andrew, after multiple rounds of antibiotics, you now are experiencing dysbiosis. And that is likely why you are having the food sensitivities, the frequent bowel movements every day. Okay, so that's different from IBS. We know what's causing that. And so what you have to do is you have to get your diverticulitis under control without the antibiotics. And then you have to work at sort of rehabbing your microbiome, lots of fiber, lots of fermented foods, no more antibiotics ideally. So you have to work out with your gastroenterologist a plan to avoid those antibiotics. And again, that's not IBS. That's medically induced symptoms as a result of the antibiotics. Okay. Can clear nasal spray with xylitol disrupt the microbiome? So I'm really glad you asked that, because it brings us to the FODMAPs issue. So FODMAP stands for fermentable oligo monosaccharides and polyols. I'm going to say that again because it's quite a mouthful. FODMAPs, FODMAPs. F is fermentable. O is oligosaccharides. D is disaccharides. So a saccharide, they're talking about a sugar molecule, basically. Oligosaccharides is multiple short chain carbohydrates that are all sort of linked together with short chains. That's oligo, multiple. Di means two, okay? Like sucrose. And mono means one, like glucose or galactose. So it's these simple sugars that are either single, double, or multiple. That's the FODM, fermentable oligo, di, or mono. And the AP is and polyols. So polyols are things like sorbitol, mannitol, xylitol. These are poorly absorbed sugars. So this is, again, you guys are just the advanced class here to even realize that xylitol is a polyol, is a FODMAPs food, and can spraying it disrupt the microbiome? It can, because some of that is going to be absorbed into the gut, but you have to be using a lot of it. Okay. We're going to get back to FODMAPs, but we've got a good mechanical question here from Jean. How does a floppy tortuous colon, and Jean, we're going to rephrase that as how does a voluptuous venous colon, because doesn't it sound much better than a floppy tortuous colon? So I want you to know you have a voluptuous venous colon. You don't have a floppy tortuous colon, but for the purposes of today's session, how does that colon affect the likelihood of constipation? Number one, first question. And number two, do colonoscopy reports routinely include whether the person has diverticulosis or not? Is it visible at the sigmoid area? So let's answer the first question, Jean. Absolutely. A floppy tortuous colon, otherwise known as a voluptuous venous colon, is one of the commonest causes of constipation, because the stool gets trapped in all those hairpin turns, it's curvy, and it is also a little bit floppy, redundant, so there's not good tone to push stool out. So that is one of the commonest causes of constipation. And do colonoscopy reports routinely indicate whether the person has diverticulosis? Not all the time. Sometimes they'll say it in the body of the report, they'll say few scattered diverticula noted, or extensive diverticula noted, or moderate diverticulosis noted throughout the colon. But at the conclusion, they'll put normal, because as I've discussed before, and I went into detail on it in that diverticulosis office hours, so go back to it, I point out that most of the colonoscopies are being done as screening for colon cancer. So if they don't find polyps and they don't find cancer, and there's not some obvious big thing like, colitis, they just say normal. So you have to go back and read through the body of the report. Okay. Is it visible at the sigmoid area? Yes, it's usually in the sigmoid area, but diverticulosis can occur throughout the colon. I apologize, but some of these questions that are not so IBS specific, I'm going to skip over to make sure we get all the IBS questions. Can endometriosis be associated with GI IBS-like symptoms? Absolutely. Endometriosis can cause gas and bloating and pain and cramping and constipation and all of those things. That sounds an awfully lot like IBS-C, doesn't it? Absolutely. And can cause diarrhea too. So if you also have some of the other symptoms of endometriosis, that might be an important conversation to have, not just with your gastroenterologist, but with your gynecologist, and see whether a diagnostic test, like maybe, some sort of laparoscopy, is indicated to try and not just diagnose, but treat the endometriosis. Do I have office hours for Crohn's disease? Yes, I have done those in the past, and we'll have another one. I can talk about Crohn's disease all day long, and taking care of my patients with Crohn's and ulcerative colitis has been such a privilege in my professional career. So we'll do another one, Sally. Okay. How do you find a doctor who really does specialize in IBS? Also, is there another med besides dicyclomine that can help with cramping? So not a lot of doctors specialize in IBS the way doctors specialize in liver disease or specialize in IBD. But what you want to do is you want to really call ahead of time, whether that's an academic medical center or a GI practice. You want to speak to the practice administrator and find out. And I would probably use the term functional GI disorders because that's a more sort of broad category, right, Renee? So I would ask, who is your doctor who specializes in functional GI disorders? And check them out. I mean, there are some folks, for example, there is a doctor in North Carolina, Doug Grossman, who did a lot of the research and literature in IBS and so on, but he's also a much older man, and some of his views on IBS, I don't necessarily agree with, and I think not all patients do. So there are people who, and I'm not trying to say Doug Grossman, he's a fine doctor, great reputation, but he has a particular view of IBS that I think is not as updated as maybe it could be. So there are people who are famous and have done a lot of the research, but they have a particular take on it. So he's done a lot of the work, for example, an important work linking a history of sexual abuse with IBS and pointing out that a lot of people who have been sexually abused have IBS. And that is true for sure, but there are lots of other things too, right? So there's, again, dysbiosis, etc. Okay. Have diverticulosis and frequent constipation. Are Metamucil wafers as effective as psyllium husk and water? No. The wafers and the capsules are not effective. They don't dissolve as well. Because my esophagus has been dilated and is open, I aspirate both Metamucil and Citracel. So I would think about doing the fiber, the loose fiber, in much smaller amounts and make sure that you're upright while you're doing it and for a certain period after. If you're not bending over, you're not lying down, you should be okay, but you have to be careful with choking and so on. And of course, there's food, right? So beans, cabbage, all of this stuff, all great. Okay. Does hepatitis B have any relationship with bloating? We're gonna, hepatitis B bloating a little too far afield, so we'll come back and do that for another one. Gastroenteritis and IBS. Thank you so much, Cynthia, for mentioning that. We have a whole category of irritable bowel syndrome called post-infectious irritable bowel syndrome. So from what you guys know about the microbiome and all of that, you probably have one eyebrow raised right now. You're probably like, what is that? What this is after an infectious episode, so for example, Campylobacter or Clostridium difficile or Giardia, after an enteric infection, which means an infection that affects the GI tract, people will find that their GI symptoms are just not the same, their bowel habits, etc. And that is clearly a result of disruption to the microbiome. We know that, and it's intuitive, right? You have something that really causes a huge change in your gut flora, and then the infection is over, but the gut flora are not back to normal, and you continue to have symptoms. So clearly those are related to a lot of the changes in the gut flora. And what's really interesting, Cynthia, is that in some of those patients with post-infectious IBS, we don't just see changes in the gut flora. We see changes also as a result of the changes to the gut-brain axis. So for example, there's a very famous experiment where mice are inoculated with Campylobacter, and we can induce changes, sort of make them more anxious as a result of the Campylobacter. Well, we see the exact same things in a lot of patients after they've had infectious episodes, where they will describe that not only are their GI habits different, but they feel like their mood has changed. I'm dealing with that with a friend right now who's been on a lot of antibiotics, and she's like, I'm having anxiety. I don't normally have anxiety. And she's been on chronic antibiotics. Again, changes in the gut flora can lead to changes in our mood. Okay, distinction on the female colon. Oh, you're so welcome for that. And yeah, and I want you to get a t-shirt that says voluptuous Venus colon, baby, so that people know to not call your colon tortuous or floppy or anything other than the magnificent beast that it is. Okay. Started having IBS symptoms shortly after having COVID earlier this year. Is there a different course of treatment when it's a post-viral condition? Chanel, thank you so much for sharing that. And I'm so sorry that that is the case. What we know about SARS-CoV-2 and COVID is that for a lot of people, the portal of entry is through the GI tract. It is the cells in the intestinal lining and it gets in that way. Remember, there are more ACE2 receptors in the GI tract than there are in the lungs. And that's why GI symptoms during COVID, like diarrhea, abdominal pain, nausea, etc., are so common. And what we're seeing is that GI symptoms post-COVID are also very common too. The good news is that a lot of these changes, these GI long COVID symptoms, seem to be related to changes in the microbiome. Remember that the SARS-CoV-2 virus itself can induce dysbiosis when it binds. We know that. And we also know that having dysbiosis when you get COVID, when you get exposed to the SARS-CoV-2 virus itself, can worsen your prognosis, increase your likelihood of having long COVID. But what all of this points to is the idea that as we improve and rebalance our microbiome, we can improve a lot of these symptoms. And this has been a lot of the focus of my new book that's coming out in November 1st called The Antiviral Gut. And I do have a whole section in there on how to do that, but that's not coming out till November 1st. And meanwhile, you're having symptoms now. So one of the things I would do, Chanel, is I would really start looking at, focusing in addition to all the other things you're doing for your post-COVID symptoms, I would really start focusing in on the microbiome. So that's basically looking at adding in fermented foods, lots of dietary fiber, making sure you're not getting any artificial sweeteners anywhere, cutting down on a lot of the high glycemic index foods, and really thinking about health of the microbiome, plus, exposure to soil microbes, all the other things. Okay. And we do have a couple office hours we've done on that. So you can go back and take a look in terms of how to rehab your microbiome. For patients who are diagnosed with ulcerative colitis, how do you know if you might also have IBS? And which is it when you have mucus in your stool or other irregular stool symptoms? By definition, if you have ulcerative colitis, it's really hard to make a diagnosis of irritable bowel syndrome. I mean, I think most of those people who say I have both, they're really attributing a lot of the IBS symptoms. They're really attributing a lot of their UC symptoms to IBS. So things like mucus in the stool, change in bowel habits, etc., unless your ulcerative colitis is in complete remission, okay? Unless, which basically means you have an entirely normal colonoscopy when they do your colonoscopy with no signs of active ulcerative colitis. Unless that's the case, you can pretty much expect that the symptoms, mucus, change in bowel habits, etc., that's the ulcerative colitis. All right. Sally, I am going to ask you to email me at digestivecenterforwellness.com, okay? Or admin at digestivecenterforwellness@gmail.com. Is there another medicine for cramping for an IBS patient besides dicyclomine? So dicyclomine is an antispasmodic, and it is also known as Bentyl, is one of the names for it. And it can work really well as an antispasmodic. It works best if you take it sort of prophylactically. So while I'm always a fan of, judicious use of medication and the less, the better, for a lot of patients with IBS, if they predictably have symptoms, like say after eating dinner or at bedtime, taking the dicyclomine ahead of time can be helpful. One of the things I love to try for my IBS patients who are having cramping is just the combination of peppermint, ginger, and fennel oil. And there's a great brand called Heather's Tummy Tamers, and they have a peppermint, ginger, fennel oil capsule. And I use it in a lot of my patients with IBS, both along with the Lamotil instead of with the dicyclomine. Sorry, Lamotil is an antidiarrheal. So they'll use it with the dicyclomine or instead of the dicyclomine. And for a lot of people, it can give them relief. Or, if you're up for it, making your own ginger, fennel, and mint tea, very soothing. I've had a lot of patients do that. How do you do that? Get some fresh fennel, chop it up, or fennel seeds, chop up some ginger, couple of handfuls of mint leaves. It doesn't really matter how much. You're not going to overdose on this stuff. Boil it, get it to a good boil, then let it steep. You can make a big kind of jar of it and keep it in the fridge and then heat it up when you need it. So that ginger mint fennel tea works really well. Also, ginger is a natural pro-motility agent. Fennel helps to increase the digestive enzyme activity, and mint is also very soothing. So that's something to try too for the cramping. And then, of course, for a lot of people having cramping, it's the visceral distension because their GI tract is full, right? So I don't know if you're IBS-C or D or an alternator, but if you tend to be more on the constipated side, what will help tremendously with that cramping is getting the stool out. So maybe using a little magnesium, a little fiber, more water, cathartic, to help make sure you're having that complete bowel movement and see what happens to the cramping. Okay. This is a hard one to find sensitive doctors and other practitioners. My recent visit with GastroDoc said that SIBO is a de jure disease. That's such an uninformed opinion, and that, you know, that doctor may be lovely in other ways, but what it says to me is that he or she is really not up on the science, and that's a little bit concerning. Okay, do antidepressants affect the gut? Yes, this is recorded. Came late in Miss Diverticulitis' class, he said would help. So go to the office hours page on gutbliss.com. You'll find the diverticulosis, and then this will be up. Usually it takes us a couple of days to get the recording, do a little bit of editing, and do a caption for it. So it should be up today. So you're generally up by Thursday. So check back for the beginning. But yes, antidepressants absolutely can affect the gut. They can affect gut motility, and they can also affect the microbiome, depending on what kind. SSRIs have been known to affect the microbiome. What I see most frequently with people on antidepressants is they become more bloated and constipated, typically. Now, for a lot of people, those symptoms will last about 2 to 4 weeks and then dissipate. But if they're lasting longer than that and they're a problem, I would talk to your prescribing doctor about maybe changing to a different formulation or decreasing the dose or seeing what else they can do. Okay. Told my issue could be diverticulosis, so I'd like to read about. Okay. My mother has type 2 diabetes and IBS-D. So type 2 diabetes and irritable bowel syndrome, diarrhea predominant. Now, remember I told you earlier that diabetes can affect the nerves in the GI tract, and they can cause one of two things: too fast or too slow. So people with diabetes can have increased transit time through the gut and diarrhea. That's a very, very common problem with people who have diabetes. And so Maria says when her mother is in a bad flare, she ends up taking Lamotil. She feels that's the only thing that helps. Maria disagrees. Would like to hear your thoughts. Okay, so here's the thing, Maria. Lamotil will help, but it can cause the other problem. So it can cause you to go from feast to famine. She's having diarrhea, she takes Lamotil, it can end up backing her up for a couple days. And then you're sort of in this, you know, swinging back and forth. And Lamotil also has some other pretty significant side effects. It does have a narcotic-like effect. There are other things that she could try. And again, I always want to point out, this is not medical advice. I'm not your mother's doctor. She definitely needs to discuss all and any of this with her doctor. But for example, if she, when you said, you know, she's in a bad flare, if her blood sugar is poorly controlled, it is likely to cause more problems. So one of the first things to do with somebody with diabetes, and this is true for type 1 and type 2, is just see what kind of control her diabetes is under. And you can get a sense of this through looking at the hemoglobin A1C. Okay, which is a glycosylated hemoglobin. And that's something her doctor should be checking pretty regularly and looking at what range she's in. And if her hemoglobin A1C is high, you know, 7% or higher, that suggests that the diabetes needs work, you know, ideally through diet, maybe she's on medication. And as the diabetes becomes more sort of well controlled, those flares involving the other organs should be not as severe. So that's number one. Number two, there are other antidiarrheals that are not as aggressive as Lamotil. So one of the things I love to use is something called bentonite clay. And bentonite clay simply binds the stuff in the GI tract and slows things down. You have to be careful with bentonite clay because it can bind medication also. So there's, you know, pretty precise instructions about taking it in relationship to any medication that you're taking. From a food point of view, a lot of my patients who are having fast motility, so I have a lot of patients with colitis who notice this, people who've had their colon removed, so things are really zooming through fast. is they will have some oatmeal in the morning, and that can slow things down. It can kind of thicken everything up. Even though we think of Metamucil and psyllium husk as something that we use when we're constipated, if you're having fast motility or multiple bowel movements, it can sometimes help consolidate things too. So those are some other things to think about, okay? The bentonite clay, psyllium husk, potentially, as well as oatmeal in the morning to slow things down. I was hospitalized with a small bowel obstruction, probably due to abdominal adhesions because of ovarian cancer surgeries. Oh my goodness. So I hope you're in full remission from the ovarian cancer. I was told to have a low fiber diet, excluding all vegetables except mashed potatoes and cooked carrots, no nuts, whole grains, etc. Told to use Miralax daily. I take a vitamin pill every day. I'm worried about nutrition. What do you recommend? So here's the thing, Shirley. When you have had adhesions and small bowel obstruction, which is, a significant occurrence, right? Sometimes that ends up being a surgical emergency. We have to be very careful about what's going in the GI tract. And a high residue diet, which is a kind of diet I would normally recommend for your microbiome, which is lots of fruits, vegetables, beans, nuts, seeds. Those foods are not well broken down, and they cause more residue, more bulk, which we want. We want a nice, big, bulky bowel movement. But if you find that you're not tolerating that, and they want to put you on a lower fiber diet and use a Miralax, that might be appropriate. It's hard to give you specific advice, Shirley, without knowing all the details of what's going on. But I will tell you that I have patients. I have a lovely patient who had radiation for ovarian cancer, and she had multiple small bowel obstructions and had more surgery. So she had scar tissue and a lot of fibrous adhesions from the radiation. And I had to put her on a very similar regimen. We were gradually, over about a 1.5 year period, we were gradually able to add in more fiber. The things I told her were just forbidden: popcorn and baby carrots. No popcorn and baby carrots. Those are the two things that I just see really triggering obstructions so much of the time. But we were able to add in a lot of vegetables through blended soups. So I had her making a high fiber soup with leeks, onion, garlic, peppers, that she would saute the stuff and then blend it. She was tolerating green smoothies blended really well. She was tolerating sweet potato, which again has lots of fiber as well as other nutrients. But she was careful with the kale and the cabbage and the Brussels sprouts and those things, right? So you want to have somebody work with you, whether it's a physician or nutritionist, who understands about the fiber content of these different foods and specifically understands the difference between digestible fiber and indigestible fiber, and understands about viscosity of the fiber, because these are all the different things that can lead to fiber, basically causing a big sort of mush in your colon that can get stuck, versus stuff that can move through and bring some water through and really help empty your digestive tract. So you need somebody with that expertise to help you with that. But I wouldn't be satisfied as just saying, basically low fiber diet for life. You want to find out how you can advance this slowly and safely, using symptoms as your guide to some extent, to get to that balance between not having obstructive symptoms or a small bowel obstruction, but also making sure you're getting good nourishment. So I wish you well on that journey. And it's okay to use a little Miralax to keep things liquid, because what we want to do in this setting is we want to make sure we avoid anything that could cause an obstruction. So it's a little bit of a special situation compared to just the average person, right? Because you've had a significant setback with a small bowel obstruction, and we want to avoid that at all costs. So sometimes we're willing to tolerate something like Miralax on a more regular basis that we might not otherwise. Okay. Do you need to avoid peppermint if you have IBS-like symptoms along with GERD and esophagitis? Not at all, not if you don't tolerate it. For some people, peppermint opens up that lower esophageal sphincter. It can lead to reflux, sort of heartburn-like symptoms. But for a lot of other people with reflux, the peppermint can be soothing. So it's really dealer's choice, and you have to try it and see. It's not going to do any lasting damage. Hi, Anna. How about motility drugs for improving IBS SIBO symptoms that are constipation related if the diet and non-other drug options are working? Let me make sure I'm reading that correctly, Anna. You're asking about motility drugs for improving IBS/SIBO symptoms that sound like you're constipated if the diet and other non-drug options aren't working. You know, these are options, but they're not great options, Anna, because most of the motility drugs that we have that are effective and safe work in the upper GI tract. Okay, they work primarily on the stomach. And the motility issues for both irritable bowel syndrome and for SIBO, small intestinal bacterial overgrowth, dysbiosis, are primarily colonic. So we don't have a good medication, a good medical option for that kind of dysmotility. That, like, things like Linzess don't tend to work very well for that. They're things that you can try, but they're not as effective compared to the upper GI tract. So still looking at, you know, and there's no reason you can't do both. So there's no reason you can't be on an agent, but also be working from a dietary point of view on things to improve the transit time through the GI tract. Okay, and let me just keep an eye on the time here. You guys are full of good questions, I tell you. Okay, we're good with time. So let me get back to this. Okay. Is there a difference between female and male GI issues? I have an interest in men's health issues. There absolutely is, Dawn. So we are physiologically, hormonally, anatomically, functionally different. The female GI tract is completely different from the male GI tract. If you blindfolded me and had me do a colonoscopy, which would be a bad idea because I have to see where I'm going with the colon. But if you had me do a colonoscopy on somebody and you covered the person up and I wasn't able to tell whether they were male or female, I think I could tell with high accuracy, high 90s, based on really what's going on in the colon and the anatomy of the colon. Okay, females tend to have, because we have a wider pelvis and it's a deeper pelvis, the colon drops low down in the pelvis in women, whereas in men, most of it is in the abdomen. And what else is in the pelvis? The uterus, the fallopian tubes, the ovaries, the bladder. So there's a lot of competition. And as a result, the female colon, that's why I call it the voluptuous venous colon, has to go around all this other hardware down there. And so the twists and turns are different. So I do colonoscopy in a lot of women, primarily more women than men. And so I like to say that's how I got good at doing colonoscopy, from all those really challenging voluptuous venous colons. But there are also hormonally differences. Last week, we talked about the estrobolome and estrogen and the specific community of bacteria in the gut that recycle estrogen. And of course, men have estrogen too, but our levels of testosterone and estrogen are very different. And that also informs what's going on in our GI tract. And even other hormones like thyroid hormone, cortisol, et cetera, there are variations, there are male-female variations in those hormones too that affect the GI tract. So yes, very, very different. Okay. Is there a solution for several loose stools in the morning and being constipated in the afternoon? That's such an interesting question, Andrew. Usually, I shouldn't say usually, often people have the opposite problem, but I would really look at what's going on at night, why you're having that loose stool in the morning. Is it something you're eating at night that you're maybe having a reaction to? Is there a medication you're taking at night that's potentially causing that side effect? Or is this just that you're having, you know, good evacuation in the morning and then not so good later on? The other thing to think about is when there is an inflammatory problem in the colon, like colitis, and colitis doesn't always mean ulcerative colitis. We see other forms of colitis. We see eosinophilic colitis. We see lymphocytic colitis. We see collagenous colitis. So lymphocytic colitis and collagenous colitis are two types of microscopic colitis. The colon looks normal when we do a colonoscopy, but when we biopsy, we see significant changes. So with lymphocytic colitis, we see a lot of lymphocytes of white blood cells in the lining. And there's a pretty strong association with gluten intolerance and celiac disease for lymphocytic colitis. With collagenous colitis, when we do a biopsy, we see a thick band of collagen just onto the epithelium. And that's what's preventing reabsorption of fluid. And that's why the stool is loose. So if you are having loose stools in the morning, I'm not as concerned about the constipation in the afternoon. You know, there's fixes for that. But I want you to figure out why you're having a loose stool. And it could be something as simple, again, as a dietary trigger, right? Maybe you're having dairy at night and you're lactose intolerant. But I also want you to think about some of these other inflammatory conditions, because they often will cause looser stool in the morning. So patients, all the way from complex autoimmune diseases like Crohn's and colitis to disorders like these microscopic colitis types, eosinophilic, collagenous, lymphocytic, often will have that history of loose stool in the morning. Not saying that you have that, but that's something that should really require an evaluation if that has been going on for a while. I want you to see somebody for that. Okay, Lynn was prescribed generic form of Effexor, not for depression, but for vertigo. So vertigo is another one of those things that, as I lose my balance here against the bookshelf, that really requires some investigation. Sometimes it's an inner ear problem. I know there are a lot of medications people use. They use things like Antivert, Effexor, different things, but there are also things that can be done. There's a procedure they do where they turn your head quickly in a special chair that can solve it. So I want you to get that evaluated too, if you haven't, with an eye to what's causing the vertigo and what can I do about it beyond taking Effexor long term. If you've done all of that, Lynn, and the venlafaxine, the Effexor, is working, see if you can get the dose down. Figure out what the minimum dose is. Like if the doctor's prescribing, X, see if half X or X every other day could work, and obviously talk to them about it. But they're often prescribing a standard dose, but many of us don't need a standard dose. We're good with half of that or a quarter of that or a third. So I want you to push out a little bit. Where on my site are the recordings? Okay, gutbliss.com, one word, gutbliss.com. On the navigation, you will see office hours, or on the homepage where we list the office hours, there's a little button that says, see all or see more. So either go to the navigation or click on that, and it will take you to the office hours landing page where you'd be able to register for upcoming office hours. We have a couple good ones coming up in August. And you will also be able to see the archived office hours, and you can click on any of them you like and watch them, or you can go to our Gut Bliss YouTube channel and watch them. And coming up in August, we're really focusing on some of these antiviral things. So we have a great one on whether fiber can protect you from viruses, some really interesting stuff there on short chain fatty acids and the gut immune connection. We have another really interesting one on stomach acid. Stomach acid has been blamed for a lot of problems. There are millions and millions of people taking acid blockers. But stomach acid is also really important for protecting you against viruses. So there's some sort of conflicting data there. We have a couple other good ones, so check them out. Okay. Have I done a talk yet on esophageal spasms, esophagitis, and or Barrett's? I haven't, but I can, and I can absolutely incorporate that into the stomach acid talk. So great suggestion, Susan. Thank you. All right. I've been diagnosed with collagenous colitis, apparently a form of ulcerative colitis. Not a form of ulcerative colitis, Hope, completely different. Ulcerative colitis and Crohn's disease are inflammatory bowel diseases. Collagenous colitis is a form of microscopic colitis, completely distinct and separate from ulcerative colitis. Okay. Is that IBD? No, it's not IBD, but it's also not IBS. It's what's called a microscopic colitis. And again, there's two primarily, collagenous and lymphocytic. So not IBD, not IBS. My primary symptom is diarrhea. Yes, Hope, that is the primary symptom of microscopic colitis, collagenous, lymphocytic. My doctor thought it might be due to yeast in the intestinal tract. Not usually. I took a med for that 30 days, but it is not completely cleared up. Not surprised, because that's not a typical cause. I was told to only eat cooked vegetables since raw food seems to be a trigger. There are a lot of food associations with the microscopic colitides, artificial sweeteners, dairy, non-steroidals. There's a lot of different ones. I would just Google collagenous colitis and go to, a WebMD, a Mayo Clinic, Cleveland Clinic site, etc., and you'll find some of that, but not IBD. Okay, and I don't like to create hierarchies of disease per se, but I will say that ulcerative colitis is a more serious condition than collagenous colitis. Not to say collagenous colitis is not serious, but in the spectrum of diseases, ulcerative colitis is sort of a more serious concerning condition. And collagenous colitis, the nice thing is if you can identify what some of the triggers are, you can put that into remission without any medication just by avoiding those triggers. We do sometimes borrow and use some of the anti-inflammatory medications we use for IBD. We sometimes do use those for collagenous colitis, but that's not first-line therapy. Triphala for constipation, not a lot of downside. Doesn't work for everybody, but fine to try. Thank you, Maria. Is IBD guard helpful for pain? If yes, can we take it daily? There's a lot of variation from patient to patient. It wasn't a product that I found particularly useful in my patients. I used a lot of Bentyl, of dicyclomine, in my IBS patients, typically low dose, but that was a drug that it can be a little constipating if you're using a lot of it. So in people who have IBS-C, they have to be careful. But in people who pain, spasm was primarily the problem, once I made sure they were evacuating regularly and completely, and that wasn't the issue, I've had a lot of luck with that. But again, I don't think that that is a harmful drug, particularly the IBD guard, particularly if you are using it, the IB guard, particularly if you are using it, according to the manufacturer's recommendation. So I think it's fine to try and see. Okay. I have had mixed IBS, so diarrhea, constipation, for about 5 years. I stumbled across Truvani digestive enzymes, largely address the diarrhea. I use Heather's acacia fiber, benefiber, Miralax daily, drink lots of water every day. Despite these, I can go 5 to 6 days without a bowel movement. Then when I start to go for several days, every time I pee, I poop. The poop is soft and not fully formed, requires 10 minutes of time for cleanup each time. Anything you suggest? Okay. If you have not had a colonoscopy recently, I would definitely recommend that you get one, because there's some things that you're mentioning to me there that suggests maybe some mechanical issues, with when you're peeing, you're pooing, and not worrisome. I don't want to startle you like, oh, I think you have colon cancer or anything like that. And also a good GYN evaluation with a bimanual evaluation, which means that they're doing a rectal exam and a cervical exam at the same time, because I wonder if there's not something going on. Maybe your uterus is anteverted or retroverted or tipped, or there's some fibroids, or there's some mechanical thing there with the uterus or the bladder in relation to the GI tract, why, when you pee, you poop. Now, when we poop, we often pee. That has to do with how the muscles in the colon, as we evacuate, can also exert some pressure on the bladder, and that's more physiological, but you shouldn't be pooping every time you pee. And the other thing we'll often see that with is with diverticulosis. So I just want to make sure you get your colon checked out. Also, the cleanup each time taking a long time, that's also typical for diverticulosis. That suggests that there's incomplete evacuation, Holly, when you go, and that not all the stool is coming out. So some of the symptoms you're describing to me where, the fiber help, the Miralax, the water, all of these things, but you're still kind of feast to famine. You're going long times without pooing. You're having a bowel movement when you urinate, and there's messy cleanup. Just make sure, the colon's been evaluated in the last few years and see if there was any diverticulosis, because it's sounding a little bit to me like that. Okay, how are we doing for time? We're almost there. How does the state of the nervous system, parasympathetic versus sympathetic, fight or flight, or dorsal vagal, freeze, affect the motility of the digestive tract and IBS-like symptoms? Yeah, great question. So we think about fight or flight. When we have to, I used to say when we have to run away from T-Rex, and my teenage daughter was like, Mommy, that's so factually incorrect. Humans were not alive when the dinosaurs were living. So please don't say that. It's very embarrassing to me, in that way teenage girls can do, followed by, did you even go to medical school that you don't know that? So let me not use that example. And let me say that if you are running away from a tornado, for example, digestion is a very active process, and it requires a lot of blood flow to some of these large vessels, a splanchnic circulation, etc. And if you're running away from a tornado, not a T-Rex, you need a lot of that blood flow to go to the large muscles, the quadriceps, the hamstrings, etc., to get away, to power you. And so usually in a fight or flight situation, there's diversion of blood flow away from the GI tract, the digestive organs, and that can affect everything from stomach acid production to motility, etc. So usually the GI tract kind of takes a back seat while you get away from whatever the danger is at hand. And when you think about it, like, it makes sense, right? Like, you're escaping, an explosion or something. But we are living with mini explosions, fight or flight, throughout our day, all day long, like things that require attention, heightened. The news, you get on here and it's like, oh, DC, highest rates of monkeypox, all this stuff is designed to really rev us up and keep us scrolling and keep us plugged in and get us into this fight or flight state. So now we are having that throughout the day, and it can affect our motility in a very sort of deleterious manner. Okay. All right, Lynn, I don't know where you are, Lynn, but I want to tell you that my friend Brian McKenzie, Dr. Brian McKenzie, who's an ENT in Northern Virginia in McLean, is an expert in vertigo, and I think he's phenomenal. So if you're in the area and you want a second opinion on vertigo, think about checking him out. Okay. I have esophageal dysmotility, mild achalasia, so I need to soften foods, overdid juice, therefore fructose, and got full-blown IBS and responded to FODMAP diet. Is it common to be able to back off the diet over time? For example, pistachio nuts and chickpeas. James, I'm so glad you mentioned this, and we are out of time and really didn't have a chance to get into FODMAPs. The main thing I want to tell you about FODMAPs is that if you look, for example, at the oligosaccharides, you look at fructans. So wheat and gluten-containing foods, wheat, rye, barley, have fructans. But what else has fructans is some really healthy foods like onion and garlic and Jerusalem artichokes that are great for the microbiome. Same if you look at galactans, you see some really healthy foods like legumes and so on. So it's a mixed bag. And I would never recommend, when you look at all the high FODMAPs foods, there's lots of healthy foods, stone fruit, which can be great for you, but they do have fructose. So this is a diet that was designed really as a diagnostic diet to see what happens to people's symptoms of gases and distension and so on. It's not meant as a long-term diet. And, any study you read on FODMAPs will also say that eliminating these foods for long periods of time can be detrimental to your health. So I think it's really important to try, if you were on a low FODMAPs diet and it helped you, for whatever reason, to try and reintroduce those foods, not so much the dairy and definitely not the artificial sweeteners or even the wheat, rye, and barley, but for some of the other fermentable plant foods, absolutely. So as you mentioned, pistachio nuts, chickpeas, definitely get some of those legumes back in, and nuts. Okay. Oh my goodness, we have so many great questions here, but it is 1:04, and just to be respectful for everybody's time, I'm going to sign off. So we're going to do a FODMAPs office hours, and we're going to do an esophageal conditions office hours. And I have a little favor to ask you. Please think about subscribing to our Gutless channel and our Gutless newsletter. I promise you, our newsletter, we do no advertising. I don't take a penny. I don't make a penny. This is all on my time and my wonderful Chief of Operations, Leslie Ann Berg's time. So this is one of the few newsletters. We have 3 main articles we do every 2 weeks. They're always really well researched, things that we think you would appreciate hearing about. And there's no advertising of any kind. Trust me, we don't sell your name or anything like that to anybody. This is just our little Gutless community. We're never going to solicit you, but it does really help to increase the robustness of our community. So think about subscribing at gutless.com or checking out the YouTube channel, gutless.com. We're just getting that going. But, we have really just one goal, which is to increase access to really, actionable, scientifically backed, practical gut health information. And we're always so glad that anytime we have a chance to interact with you, but do think about giving us a little subscribe. Okay, bye everyone.